Well, thank you so much. It's a real honor to be here, and thank you for setting it up. All of our schedules can be challenging, but this is one of those very unique opportunities for us as clinicians to work with people who are much smarter and more interesting than we are, who give us a different point of view of what we do every day. And I think one of the real challenges in medicine is, we see thousands of patients a year, do hundreds of surgeries a year, but we tend to look at things as how can we fix the problem that's facing us currently with what solutions we have available currently, because that's the pressing issue. Somebody comes in with an issue, how do I fix it with the techniques I have now? So when I was honored enough to be asked to speak with at the Unmet Clinical Needs seminar, I started thinking about it. We initially were scheduled back in the spring, and I had to cancel the last minute, so it gave me an extra 6 months or so to think about it. And I would like to say that those 6 months really helped, but what they did is almost confused me a little more. And I realized coming up with the unmet clinical needs are challenging because you have to identify what flaws there are in your own practice, what things we can improve, and then I think one of the real reasons why we're all here today is to look at the experts and the smart people in the room who can say, we can help you fix that, or we have solutions for that. We didn't even know that it could be a problem, say, in spinal surgery. So as Bruce said, I'm the chief of the spinal surgery service in orthopedic surgery. We run a very busy clinical practice, myself and my three partners. Doug Keister is here. Doug's been at the university for over 15 years and is quite an inventor and holds multiple patents himself as well. So he I think will be a great addition to the group today. I wanted to start with kind of a basic outline of spine. Spine, even for MDs, is kind of a unique animal. You don't learn a lot about the spine in medical school, surprisingly. And even orthopedic surgeons who aren't spine specialists don't know that much about it. Same with neurosurgeons who aren't spine specialists. So it's really a subspecialty unto itself. So I wanted to go through some of the basic anatomy. So when we're talking about things, whether it's the vertebral bodies or the discs or the nerves, we all have the same basic background. Then I wanted to talk about some of the common back problems, the ones that we see every day that involve the vast majority of the American population. And then finally, treatments that we've used for years, as well as treatments that we may use in the future. So let's talk about the anatomy a little bit. Really, the anatomy is based around the function of the spine. And the spine simplistically has three basic functions. One is stability and protection. One is to allow some motion and flexibility. And finally, it serves as a conduit for the nerves to travel from the brain down to the end organs and extremities. So for the stability and protection, that's where the vertebra or bones come in. There are 7 vertebrae in the neck, 12 in the thoracic spine, 5 in the lumbar spine, and then 9 that are fused into the sacrum. Really, the area where we see the most problems are the neck and the low back, and that's because that's where all the motion is. There's not a lot of motion in the thoracic spine because the ribs create a very rigid cage, almost like a barrel, where you don't see much motion, you don't see the wear and tear on the discs and the joints, so you don't develop the classic degenerative problems that you see in both the neck and the low back. So, greater than 95 or even 98% of the surgeries we do are either cervical or lumbar, and they're due to degenerative causes, not trauma or other issues. The bones have space for the spinal cord and nerves that are in the center of the bone. They also obviously provide bony stability. And then the question is, well, if we have all these bones, how does the spine move? How can we bend over and touch our toes? How can we twist our neck? Well, and that's where the discs come in. And the discs are the intervertebral discs because they're in between each pair of vertebral bodies. On this diagram there, the vertebral bodies here are this kind of yellow beige, and the discs are the white. So the discs are smaller than the bones, and the discs allow motion, and they serve as shock absorbers as well. The discs have a very unique structure. They have to really resist all forms of motion, twisting, compression, tension. So the outer annulus has this kind of almost random pattern of annular fibers that allows it to take place. And then finally, how do we get the nerves from the brain down to the arms and legs? And that's where the spinal cord and spinal nerves are. And so this is what it looks like this is an MRI scan. The bones and the discs are in the front here. Some of the bones continue to the back as well. Here's the spinal cord coming down from the base of the brain, surrounded by the good white bright spinal fluid. It's a pretty normal looking MRI scan of the cervical spine. The nerves leave the spinal cord at each level, one to the left side, one to the right side, and each provide very specific patterns. So for example, the L5 nerve may travel down the outside of the leg and give us strength function to raise our foot and raise our toes. So those are the main, the function of the spine and the basic anatomy: bones, discs, nerves, and as long as they all work together, everything's good. When they start to not work properly, whether it's from degenerative causes or acute injuries, that's when we develop clinical issues where people come to see us. Spinal problems are extremely common. Probably the second most common reason people go to see medical doctors in America, second only to the common cold. So it's literally billions of dollars. The most common one we see is just good old-fashioned low back pain. And two of the more other common things that we see are spinal stenosis and disc herniations. We'll talk a little bit about those. So low back pain. The reason I kind of sarcastically call it everyone's favorite topic is because it's very challenging to treat. I'm sure everyone in here at some point has had some sort of low back pain in their life that probably laid you up for a couple days, and if you haven't had it, I'm sorry to tell you, you will have it at some point. It's challenging for clinicians because it's very hard to diagnose the exact cause of it and then hard to treat it. And the diagnostic issues with back pain are that our tests, our x-rays, our MRI scans, our bone scans, don't really give us specifics as to what's causing it. Is it muscle spasm? Is it joint inflammation? Is there a little protrusion in the disc that's making the disc cause what we call discogenic pain? And really the diagnostic modalities for back pain really are lacking in general. When I talk about low back pain, I'm talking about back pain in the back or sometimes in the neck without neurologic symptoms. So we're not talking about nerve pressure. We're not talking about sciatica. We're talking about what we call axial low back pain. It's not whole body pain. This is what we call a pain diagram. Patients fill it in. So they got little different things for all the pain they feel. This patient brought in all their own markers as well, and that's always a bad sign. So this kind of pain, I don't care how good of a surgeon you are, you can't really fix it. That's a whole different problem, more for our psychiatry folk. So who gets back pain? At some point in their life, 80% of the American population will see a medical practitioner for back pain. It's an annual incidence of 15%, and it costs the U.S. over $80 billion per year. And why so much money? Yeah. So it includes chiropractors, physical therapists, and medical doctors. $80 billion a year. Why so much money? Second most common cause of missed work, second to the common cold. 33 million ambulatory care visits per year, and over 500,000 hospitalizations, and that was 14 years ago, so clearly that number's gone up significantly. If you go to Google for back pain, because you have to have a lot of free time, because over 25 million matches for possible solutions for your back pain. So maybe you'll go to Amazon and buy something that helps you. Hope you have a lot of money because it's 2,000 products, and now you have to pay tax as well, so even more. So lots of issues out there that are written about in scientific literature, common literature, because it's so common. And so the fundamental question is, why do we all get back pain? You know, we could be fine on Monday and Tuesday and wake up Wednesday and our back could be killing us with nothing different. And there are numerous causes that can lead to back pain. You can have chronic arthritis, you can have a disc protrusion, you can have a muscle problem. It can even be things like mental stress can lead to back and neck pain. And one of the most common problems we see is bony problems and disc degeneration. Essentially, that's arthritis. This is a process that occurs in everybody. If you get an MRI scan of men ages 20 to 22, so very young men, otherwise healthy, no back problems, the majority of them will start showing changes in their discs from a normal disc to fissures in their disc, bulging discs, to where you get bone spurs as we kind of head down this spectrum. So even at age 20 years old, this degenerative process is already occurring in the majority of people, and it progresses more with time. You can also have problems with the discs and the nerves. You can have nerve irritation. As specifically the dorsal primary ramus or the dorsal ramus, which is a small branch of the main motor nerve. This is actually a pure sensory nerve that then innervates the facet joints, which are small joints in the back of the spine, the ligaments, and the muscles. Now, if you have pain coming anywhere in the spine, the brain can't tell us, it's from my left dorsal ramus at the L4 level. It all just feels the same. And there's no way to selectively identify where it's coming from. In fact, one of the treatments people use nowadays is what we call a rhizotomy or RF ablation of these little ramus, almost trying to diagnose it and treat it at the same time, because you treat it, if it doesn't help it, well, maybe it's not that level, it's another level. And then muscle dysfunction. This is a very common cause of back pain. You lift something wrong, you're gardening too much, muscles go out, muscles have spasm or strain. When we're trying to make the diagnosis, we use a variety of treatments, including things like bone scans and MRI scans, sometimes laboratory studies. This is what an MRI scan will look like. This is a pretty normal looking scan. The discs should look kind of bright and tall. These are a little bit darker, a little bit of bulging. That's a mild degenerative change. There's a very high rate of positive MRI findings in asymptomatic patients. And so seeing that bulge doesn't tell me that's causing their pain by any means. One of the reasons why spinal surgery has so many failures is surgeons look at the MRI scan and say, well, you're having horrible back pain for 2 years. That disc looks a bit degenerative. Let's do a fusion of that disc, or let's replace that disc. And it's truly a flip of a coin if you get better or you get worse. And I think that's one of the real issues in spinal surgery is how do we diagnose what's causing someone's chronic pain? Not pain that's been going on for a week or two after they go to the gym, but pain that comes in and day out that you've had for a year or two. It literally affects millions of people. We don't have a good diagnostic tool for it. The differential diagnosis for back pain is numerous, but clearly one of the most common is muscle. Another more common is probably disc or joint-related problems. For children, similar kind of a diagnosis protocol as well. For back pain, for what we call acute non-specific pain, most people get better. Most people, it's a muscle strain, treat them with some anti-inflammatories, day or two of rest, get back to normal as soon as you can. But you really, for those people, we really have to make sure that you do the right thing. Keep your muscles strong, don't gain weight, don't smoke. There are some acute causes of back pain that have specific reasons to them, and some of those we can fix. You can have a trauma. This is a thoracic spine fracture dislocation, so this part of the spine should be attached up here. Obviously, very different problem than just someone with a back strain. You can have tumors or infections, and one of the big advances for spine over the past 10 or 20 years has been the treatment of osteoporotic compression fractures. Those are fractures that occur in the elderly. Almost 1 million of them occur a year. And they just happen because people's bone gets softer as we get older. It most commonly affects older women, especially fair-skinned and thin women. And what happens is, as I'm sure some of you know or all of you know, the bone changes from normal thick trabeculae to very smaller trabeculae, big air pockets, and clearly not as stable as the normal bone on the left. This is kind of a classic picture of the same woman, 50 years old, 25 years old, as you develop multiple small compression fractures throughout the thoracic spine, leading to that classic forward bend we see in people. Again, she's kind of the classic person at risk for it. Thin, female, over the age of 40, fair-skinned. So they can also be caused by tumors, but really the most common cause for sure is osteoporosis, which is a ubiquitous problem, especially in females. We can try different treatments, narcotics, bracing, very poorly tolerated. So in patients who have a lot of pain, treatment that came out about 10 or 15 years ago is something called Kyphoplasty, in which a small balloon cannula is actually inserted into the bone. The balloon is opened up to create a pocket in the bone. The bone is soft, so the bone will just move to the sides and create now a kind of a dead space. The balloon is then deflated and removed, leaving that defined cavity, and it's then filled with cement. And this is what it looks like. There's a compression fracture now with the cement in it. There was actually a procedure like this that's been out for 20, 25 years called vertebroplasty, very similar, where you put cement into the broken bone to stabilize it. It's kind of like an internal cast. Interestingly, kyphoplasty really caught on from a business point of view. They did a really good job. developing a small set of tools, so it's a single peel pack. They got people trained on it. People felt comfortable thinking that you were making this space. Interestingly, it costs more than vertebroplasty. It takes longer, and results are the same. But the company was eventually sold to another company, and then anyway, the company got sold for about $1.5 billion, and they do about $50 million of sales a year because there's that much thought that it would be that big. Probably not a great purchase, but for the things in spine that affect a lot of people, there's a big desire for big industry to be involved with it because it affects everybody. So kyphoplasty, something that does work very well. There are other options to it, but it's minimally invasive, safe, reliable, and as the population ages, will be used more and more. So for people with chronic back pain, this is very problematic. Can we do surgery for them? There's a good study out of Sweden looking at this where they compared, good randomization. I won't go through all the details, but essentially the groups were fairly similar. What they found was that people who had surgery for their back pain actually did a little bit better than people who didn't have surgery. So the overall better, a much better, and excellent were upwards of 80% for surgery versus 30% without. But there was a high rate of complications, and really getting people back to work were still only about a third. So it works, but it's not a home run kind of work. And one of the reasons it probably doesn't work that well is that, again, this is a very highly selected group, one-level problem, is that the surgeries fuse, we can put the screws and rods, and that's technically easy. It's identifying who has a problem that we can fix on the diagnostic side prior to the procedure. That is a big issue. So there's a variety of options. One of the options that has become popular or developed in Germany in the 80s and now used in the US in the past 10 years is something called a disc replacement. And the idea behind this is that instead of a fusion, you put a mobile device into the disc space. The theoretical reason is that it can avoid what we call adjacent segment disease. And the theory behind that is that if you fuse a level, the biomechanical stresses from that level get transposed on the levels above or below and may increase the rate of degeneration of those levels. The clinical studies looking at it are very mixed, whether or not it actually occurs. When I was at UCLA, we published one of the biggest studies looking at it. We didn't really see a lot of correlation with the fusion, but other studies have. And so this has created a push to use these disc replacements instead of doing fusions, with the idea being they move a little bit and that you preserve the disc level above and below. The long-term data really hasn't been developed in the U.S., and most short-term data shows that it's probably equivalent to fusion, but most studies are industry-sponsored. This actually, in 2004, 2007, there was probably 3 or 4 companies developing these for use in the U.S., and companies invested upwards of $2 or $3 billion on these technologies. The first sets of them for the lumbar spine have actually failed, and in fact, this first one, called the Charité, is no longer sold or made in the United States. But probably one of the issues is that the biomechanics in the lumbar spine hasn't really been replicated. And additionally, even if you can make the patient bend forward and backwards, you're still not recreating torsion, compression. Also, you lose a lot of those other motions that otherwise would be available.
What's the material?
So each one is a little bit different. This one is a polyethylene plastic and then titanium. One of the other more common ones now is all titanium, all metal. And so there's a variety of metals they use. Probably the most common metals we use in spine or in orthopedics are titanium, cobalt chrome, and some sort of either plastic polymer like polyethylene, which we use a lot in total hips and total knees. So surgery for low back pain, right now it's really last resort only. And this is a huge patient population who come to our office and we say, hey, we can't really help you because even though we've got MRI scans and CAT scans and all these things, we can't really identify the cause of your pain. And if we can't identify it, we can't fix it reliably. So a couple other things I want to talk about briefly. Spinal stenosis. Now, this is one of the most common reasons we do spinal surgery. Yeah.
In the slide you just showed, you said only for patients who don't have psychiatric illness.
Because spine is a field that has been clearly shown that people with certain kinds of psychiatric illness, and I should probably qualify that. People who especially have psychiatric illness where they tend to portray their mental stresses as physical stresses, and people in medical legal issues, so people in a workers' compensation situation, lawsuits, where there's some financial gain at the end, have significantly worse outcomes than people not in them. And those are probably all mental reasons.
Question, you said with the replacement discs that they're mainly metallic components.
Yeah.
But the intrinsic discs themselves are very soft.
That's right.
Why is there just no material that would stay in place?
So and that's one of the big questions is there a material, can we make a disc that has better compliance, that allows the disc to do more of what it's supposed to do? As of now, no one's really been able to come up with it. I think that'll probably be a big step in the right direction for discs. So honestly, that's part of kind of the art of medicine. So there's some people who have psychiatric illness. I have patients who have schizophrenia, and they need surgery. They have a bad problem. You have to fix them. That's okay. It's really much more of the people who have something else to gain from surgery, whether it's a financial gain. Some people just an emotional gain. I've seen people so someone who, for example, is hit by a car and they're suing the person who hit them, or they're out of work on a workers' compensation lien. If they have surgery, they get more disability money the rest of their life. And so, in fact, most spinal studies will exclude those patients from the study because we know that they do significantly worse in the short and long term than people not without those issues. So spinal stenosis. This is a narrowing of the spinal canal that results in pressure on the nerves. This is usually due to chronic degenerative arthritic changes. Because it's a chronic degenerative problem, it occurs as we get older. So it's about 1 in 1,000 people over the age of 65 years old. Now, a small number of people actually are born with congenitally narrow canals, and they may have this problem earlier in their 20s and 30s. But in general, we're talking about people over the age of 50 or 60 years old. When you have compression of the nerves in the low back, it affects the legs. Sciatica. You have numbness, pain, weakness shooting down the legs. Patients sometimes feel like their legs are heavy and they can't walk or move. Leaning forward actually opens the space in the spinal canal by stretching out a small ligament in the back of the spine called the ligamentum flavum. And it can open the space enough where people's symptoms go away. There's a couple devices on the market now which are specifically designed to just open the space up a little bit between the spinous processes and stretch that ligament to open the space for the canal. They probably open the canal space about 12%. But for people with kind of moderate symptoms who want a moderate relief, it can work quite well. But it's probably only lasts for a few years, and then the degenerative process continues and it gets tighter and a more permanent thing needs to be done. In the neck, similar kinds of problems, but they affect the arms. So nerves coming out of the neck, get the arms. Nerves coming out of the low back, get the legs. You can have a lot of problems using your hands. In Japan, a classic question is, are you having problems using chopsticks? Changes in signature, problems with balance are common for the neck. When you get x-rays on patients with these symptoms, again, it's an arthritic chronic degenerative problem. So this is a straight ahead x-ray of the low back. It should be nice and straight, but because the discs are all worn out, the spine is actually starting to curve to the side. And on a side view x-ray, this is lumbar 4, lumbar 5, the normal disc spaces are nice and plump, but look at this disc, completely collapsed, bone on bone. This bone has started to slide in front of the other one. These are all very chronic, degenerative kind of changes that we see every day. With the MRI scan, which is the optimal method to look at nerve compression, normal scan over here, lots of space. Here again are the bones and discs. The nerves are the gray within the spinal canal, and then the white is the good spinal fluid. If you look at the stenotic level, you see how the nerves are really getting pinched off. The majority of the compression tends to occur at the level of the disc. So you'll actually see where the discs are is where it gets pinched off. Behind the bone, it's not nearly as pinched. And the reason is, as we get these changes, it's the discs that start to bulge. The bone doesn't change its anatomy. The discs are bulging back, and the ligamentum flavum, which is a small ligament in the back, tends to fold in on itself. and that also occurs at the level of the disc. So literally it's this very, even though this patient has it all the way up and down their spine, it's these very acute areas that lead to the stenosis, where you have these soft tissues, the discs and the ligament, that can fold in on themselves, that tend to bulge as the disc collapses a little bit, that lead to the nerve compression.
Is that bulging? Is that actually material inside the disc that's herniating from that sort of collagen network that's keeping it contained, or is that just the disc deforming overall?
It's a chronic overall disc deformation. So it's not a true herniation of the inner jelly of the disc out of that outer container. This is a slow, gradual process. It's like if you take a jelly dough and slowly push on it, it'll kind of gradually enlarge in all positions. That's what's happening here. And so it's still contained.
It's actually a degradation of the collagen itself.
That's exactly right.
Alteration in the collagen integrity.
That's exactly right. And so this is, again, those findings we kind of reviewed. And this is what it looks like on an axillary cross-section view, wide open canal, nerve rootlets in here. And you see here how you lose all of that white spinal fluid, nerves are clumped together, and that's what leads to the pain. So you could try a variety of treatments, therapy, injections, anti-inflammatories. Do they work? Works for about a third of patients. The problem with stenosis is it's a chronic progressive disorder. So it's not something the body can fix on its own. And so even if patients get temporary relief, people with stenosis tend to need surgery. A recent government-funded prospective study actually looked at patients with stenosis and these symptoms. What they found, the surgical patients did much better than the non-surgical patients because you just have to open the space. You've got to root that canal to get it opened up. So people have surgery, people with intractable pain, lots of impairment that goes on with that response to treatment. And really the goal is very simple. You have to remove the pressure from the nerves. And in general, spinal surgery has two main goals: removing pressure from nerves and keeping the spine stable. So either restabilizing an unstable spine or preventing instability from a surgery we may do. So does surgery help? It works very well. Greater than 85% good to excellent results. It really helps the symptoms down the leg. You take the pressure off the nerves like it, leg pain goes away. If people have a lot of back pain, again, much like we talked about before, the back pain is much more variable whether or not it gets better, probably 50 to 60%. And this is a problem of our older patients. You're looking at patients who are ages 70, 80, and 90 still have excellent results. So in general, stenosis, it's a chronic progressive problem due to that gradual bulging of the disc. That disc loses height, so the ligament in the back starts to fold in on itself, and together they cause the compression on the nerves. The last thing I'll talk about is disc herniations. And herniation's a little bit different. This is kind of what you were alluding to, Bruce, where the jelly inside the disc actually pops out. This tends to occur in younger patients, people ages 20, 30, and 40. This is, for example, a common MRI scan. See, this patient, you can tell, nice plump discs everywhere. Even this area, which has a large herniation, nice and tall, not the same kind of collapse we saw in the other scan. It's a younger patient who, unfortunately, the jelly has popped out and is now crushing the nerves at that very specific spot. It tends to be very sudden. Sometimes people say they're lifting something or playing sport, but in general, it's not that. Generally, people just wake up at 5 a.m. and their leg is on fire from the herniation. This is what it looks like on a scan. It's a little bit different scan contrast, but you see the herniation here pushing out on the nerves. It's usually one side or the other because there's a big ligament called the posterior longitudinal ligament that runs right down the middle behind the disc. So as the jelly pops out, it won't try to push that ligament off. It'll go to the side of the ligament. So it'll tend to be either left side or right side in a very specific pattern. Patients who are having pain down the left leg will tend to twist their bodies to the right to open the space for the nerves. And again, if you have it in the neck, it affects the arms and hands, and in the low back, affects the legs and feet. So on exam, people can be weak. They can have nerve irritability, meaning that it hurts when we test them. X-rays look pretty normal. It's younger patients, not a lot of arthritis, but MRI scans what shows that big herniation. Fortunately, most patients don't need surgery. Now, this is different than stenosis. Remember, stenosis people needed surgery because it's a chronic, gradually progressive disorder. Chronic, gradually progressive disorders, in general, mean the body can't fix it. If the body can fix it, it's going to take care of it and stop the progression. Herniations are an acute disorder. They're not a chronic disorder. They're not a progressive disorder. They happen, and then the disc herniation's sitting there. And they can be miserable, but 90% of patients get better without surgery because the body goes in and kind of eats away the disc herniation that's there. So we do things like anti-inflammatories and steroids and epidural injections, and most patients start getting better at about 4 weeks. And usually by 3 to 4 months, 90% of patients are almost completely resolved. For those who don't resolve or have a lot of weakness, we do surgery. And the classic surgery is something called a microdiscectomy. It's a very successful surgery, greater than 90%. It's fairly simple. We make a small incision, less than an inch, go in and you just pluck out that piece of extruded jelly that's sitting there. Patients wake up. It takes about an hour. Patients wake up. Their pain's all gone. They go home the same day. So a very successful procedure for those few patients who actually need it. We can also do it with what we call minimally invasive techniques, where we make a small incision. This is really one of the issues of spine surgery, in that surgeries do tend to work very well for patients with stenosis and nerve compression, but it can be a fairly significant undertaking. A big incision, hospital stay for 4, 5, 6, 7 days, sometimes longer. And one of the reasons isn't the actual work we do on the spine. It's not taking the pressure off the nerves. It's not resecting the disc. It's getting to what we're going to do. So this is a cross-section of the low back. In order to get to this disc herniation, classically we make an incision right down the middle, and we spread all of this nice, healthy muscle to the side. We hold it to the side during the procedure. The muscle can die. The muscle hurts. It's very painful. So minimally invasive procedures allow small tubular retractors to get to where we want to work through small incisions. This is an 18 millimeter tube, which we can do an entire surgery through. Now, we are somewhat limited. Very specific pathologies currently can be treated with these less invasive approaches, whether it's unilateral or bilateral. We can even put screws and rods through there and put big cages in. But again, there are some limitations in that we have to make sure we can appropriately treat the patient's pathology, take the pressure off the nerves, stabilize them as we need to. Thank you.